Now I am really excited to introduce Jennie. She was a student of mine in two different classes, and she just graduated. She was one of our 2020 graduates who unfortunately we had to say, well, I guess we really didn't say goodbye to you, Jennie, but I was going to say we had to say goodbye virtually. Um, so we're really excited to have her come back and speak, and also have her as part of the vaccine class for semester. So tonight she's going to be speaking on COVID-19 and children, which is very appropriate because she is a child life specialist at Hershey Medical Center. Tonight she's specifically going to talk about an overview of existing literature for incidence rates of COVID, clinical presentation, and reproduction numbers in children around the world. And this might be a little bit familiar to you because she and our other speaker, Heather, who I hope makes it on, were featured in a really nice write-up after they graduated. I shared it on LinkedIn and in a couple different places. So you might have seen it, but now we get to hear about her research a little bit more in depth. So Jennie, I'm going to turn it over to you. Thank you again for speaking tonight.
Thank you so much, Dr. Aztec. So like she said, my name is Jennie. I'm a certified child life specialist at Penn State Health Children's Hospital and also a recent graduate of the Public Health Preparedness Program. So tonight I'm going to talk to you a little bit about my independent study project that resulted in a literature review and a final paper that was submitted back in August. So some of this initial information might be a little dated considering, the COVID-19 pandemic is still relevant and we continue to learn new things about it every single day. So let's get started. So oopsies, I already skipped. So one of the things that kind of drove me to picking this topic for my independent study was that we kind of knew what was happening over in China. We knew that there was an outbreak that was going on with pneumonia-like symptoms. We didn't really know where it originated from, but we knew that it was spreading very quickly and that people of all ages were susceptible to COVID-19. So then it became pretty real for us in the United States. And we started to notice some challenges and the impact that COVID-19 was having on children in their daily lives. So for one, because of the lack of information that we had about COVID, we felt that it was necessary to close schools and daycares. So schools for a lot of children plays a bigger role than just education. For some kids, it's their source of food because their families aren't able to afford to feed them for every single meal. For other kids, it's a safe space for them to come because of abuse or neglect at home. And for kids with disabilities, it also serves as a source for their therapeutic resources, such as speech and occupational therapy, and provides them with an opportunity to socialize with kids that are typically developing and at their age. Another thing that parents lost or children lost as well is their therapeutic services that were coming into their homes and providing them services, whether it was speech therapy, PT, OT, or early intervention. The hybrid and virtual learning really threw everyone for a learning curve because, a lot of parents weren't really sure how to help their children. They may have learned the material a while ago, maybe not the same way it was being taught now. And then you also have parents or caregivers who were essential workers and couldn't be present to supervise their children and making sure that they're being engaged in their learning. And then some parents also may have had conflicting work schedules and just couldn't help support their children. And one of the other things too was just the lack of socialization. So for kids who are younger, they often learn through play and interaction through their environment. So for them, it was much more than just socialization. It's learning about their environment around them. And for teenagers especially, this lack of socialization really hit them hard because they're in that stage of development where their identity is within their friend groups and their performance in school academically, as well as the activities that they choose to be involved in. So as a result of that, we've been seeing an increase in suicidal ideation and attempts in teenagers, an increase in eating disorders, and an increase in self-harm as well. Another thing we noticed from a healthcare perspective and from a pediatric perspective was that there was a heavy restriction on visitors at our hospital, specifically at Penn State Health. So any adult patient wasn't able to have a visitor or support person for them. And for our pediatric patients, they were only allowed to have one parent. So that posed a lot of stress on the parents who maybe were single parents or a blended family who had, multiple moms and dads, things like that. And then siblings also weren't able to visit. So that was just really problematic in many ways. You didn't really have that typical family-centered care and support that you would typically see in a hospital, which left a lot of kids sitting in a hospital bed by themselves. Another thing too, that thankfully our hospital didn't really have as big of an impact or issue with was the only allowing essential personnel to be working at the hospital. So our hospital specifically recognizes that psychosocial services such as child life, art therapy, music therapy, social work, chaplains, they are all considered essential personnel at our hospital. But for other hospitals, and those programmings, they were not as lucky. So they were not being able to go into the hospital and provide those services that they typically would for our pediatric patients and families. We also can't have volunteers right now, and we didn't have pet therapy. So all of our typical programming was non-functioning and still is for the most part. Our playrooms still remain closed. So those are essential for normalizing the hospital environment and helping patients engage in interactions with one another, with permitting that they are not on any type of isolation precautions. PPE can be really scary for kids. So some ways that we've kind of tried to overcome or adapt to that is adding stickers to face shields and masks, and also printing pictures of ourselves without the PPE on, and kind of taping it to our PPE so that kids can see that we too are normal looking people and not just scary people with masks. Communication has been an issue. Communicating with patients, especially who are hard of hearing or are deaf, that require lip reading in order to understand and communicate. And then another issue that our hospital has faced, as well as other hospitals, was that we require COVID-19 testing prior to anything that involves sedation. So whether it's a procedure, whether it's surgery, any type of sedated scans, things like that, kids are required to get the nasopharyngeal swabs, which can be not only stressful for the children, but for the parents as well. So knowing what I knew as a healthcare professional and as someone who works with kids, we didn't really know what the role of children was in the spread of COVID-19. And we knew that kids were out of school in China for a holiday when COVID-19 began to spread, and that there were strict lockdown measures that were being taken. So we really didn't know, how would having schools remain open affect the epidemiological spread here in the United States. We also didn't really know how many children were actually sick or exposed at the time, because any children that may have been exposed may have not gotten tested or received medical care because their symptoms weren't severe enough. With the limited testing. And then we also didn't really know, what kind of symptoms are children presenting with? Are they asymptomatic? Are they typically milder symptoms than adults? Or does it affect them more severely? So that kind of led me to my project and the study questions that I have listed here. So the things that I wanted to know about COVID-19 and its effects on children were, what is the incidence rate of COVID-19? So in children under the age of 18. So what percentage of the population that's being infected is pediatric patients or children? What does that look like in children? Do they present more asymptomatic? Are they more severe than we realized at the time? And what is the reproduction number for COVID-19 in children? So that would give us an idea of how contagious the disease was in children, and give us an idea of the types of restrictions that we would have to place on things such as school and daycare. So I conducted a literature review using our Lion search in Google Scholar, looked at a variety of keywords and combinations such as COVID-19, children, incidence, clinical presentation, reproduction number. And after sifting through thousands of articles that had even the slightest mention of COVID-19 or children, I was able to come up with about 9 articles, and those searches were conducted consistently between May of 2020 and August. So we'll start with COVID-19 from what I learned and what was presented in my paper. So first, we're going to start off with the incidence rates. So the first 2 articles, the Q and the Liu et al.'s, they were the first papers to come out. They had the earliest samples in studies that were conducted, and they were conducted at around the same time. So it was important to note, though, that the Q et al. Had a larger sample size than the Liu et al., making me believe that the results of Q et al. Was more representative of the community and the incidence rates of children at that time. But it's also important to note that both studies examined kids under the age of 16. That's what they classified children as. So it means that there may have been some children in some cases that have been missed. We also have to keep in mind, too, that the testing was not as prevalent as it is currently. The Meskina article came out of Russia, and it reported an incidence rate of COVID-19 in children to be about 6.3%. And we'll kind of go into that in a little bit more detail in a minute. But the phosphate barbate article had a rate of about 1%. And then lastly, towards the end of July, the CDC had announced that there was an incidence rate of approximately 1.7% in the United States. But one of the limitations of the study was that there was a lack of sufficient data as a limitation. So this was due to the lack of testing and data collection because it was left to the states. There was inconsistent data collection and just lack of testing and having strict criteria at the very beginning. So going back to the Meskina article, that article had the largest sample size, the most consistent data collection. So we believe that the Meskina article at the time was the most representative percentage or incidence at that period of time. So they had done a lot of testing. So anybody that in a family that had tested positive for COVID-19, the entire family had been tested. So it was more representative of a community spread and a community sample. So whenever schools were anticipating on reopening or questioning whether they were going to reopen in August, we anticipated that that percentage was going to be higher in the United States. So for clinical presentation, you'll notice it's kind of all over the place. So early on, we didn't really know what it looked like. If there was data on pediatric patients, there wasn't really any specifics about what their symptoms were. It was either listed that they had tested positive and that was it, or negative, and not much else was given about that. But ultimately, the same thing kind of persisted. So the Meskina article we felt was the most representative of the data, which meant that approximately 62.2% of children at the time presented as asymptomatic. So again, with the CDC, it had our clinical presentation rate to be about 68% of kids who stated that they didn't have a cough, fever, or shortness of breath. But again, because of the insufficient data recording, we couldn't be entirely certain that that was the correct number. Lastly, we talk about the reproduction number. So a reproduction number greater than 1 just means that an epidemic is growing, while a number less than 1 means that it's slowing down and may eventually end. So it appears that the reproduction number remained relatively steady over time. Initially, it was determined by Zimmerman and Curtis that there was a reproduction number of about 3.6 in Wuhan, China in January towards the beginning of the outbreak, which means that for every person that was infected with COVID-19, they were infecting almost 4 other people. So in February, once those lockdown measures were in place, that number went down and decreased to about 2.7. And with the Messina article, they reported a reproduction number of about 3.8. So again, this number is pretty high. And what we can conclude from this very small collection of data, that the reproduction number early on in the pandemic was somewhere around 3.6 to 3.8, depending on the country and the types of regulations and restrictions that were in place. So what can be concluded from my literature review was that people of all ages were susceptible to COVID-19. Children may be less likely than adults to contract COVID-19 and also present with less severe symptoms. They also were less likely to die from COVID-19. It is suspected that most of the pediatric cases of COVID-19 at the time were as a result of a household exposure. So a parent or someone from the extended family that lives in the same household had contracted COVID-19 first and then passed it along to the child. That the incidence rate was about 6.3% for COVID-19 in children, and that 62% of children presented as asymptomatic who were COVID positive, and that, again, the reproduction number was approximately 3.6 to 3.8. Some of the limitations to this study. So I kind of touched on this at the very beginning. So the definition of children or pediatric patient varied from study to study. So you had some studies that were classifying children as under the age of 19, anybody under the age of 18, and even under the age of 16. So it was hard to get a good picture because some data could have been excluded in some of those numbers. Smaller sample sizes for some of these studies could have also thrown off some of the numbers as well. Children getting tested less frequently than adults, the sensitivity of the tests, symptoms may have not been reported accurately. So trying to get a child to report symptoms accurately may be a little bit more difficult because their sense of pain and symptoms could be interpreted differently than what we would interpret it as adults, depending on the age of the child and the developmental level. Data collection, in the United States varied in how they collected it, and testing practices were different everywhere as well. So now I kind of wanted to give you a picture of what COVID-19 looks like today and bring you up to speed on what the most recent data is showing on COVID-19 in children. So when I went to submit this final paper, the worldwide cumulative total of cases was approximately 20 million, with a cumulative total death of about 733,000. So as of November 1st, so this past weekend, our worldwide cumulative cases has doubled, and then our total deaths has increased by 160%, and that's just a 3 months difference. So a little concerning that it's still continued to increase the way that it has. I wanted just to give you a visual comparing COVID-19 in children and adults. So you can see here, this is kind of the cutoff for pediatric patients here for children. They are less likely to, or consist of less of the cases in the United States than the adults. And then if you look here, it's the same trends that we've been talking about or we've been seeing in the news about how the older populations are more likely to have more severe complications and death from COVID-19. So I thought that was just a good visual to kind of to see, kind of how that looks on paper. So the incidence rates, this is taken from the American Academy of Pediatrics. They just updated this, I want to say on the 29th of October. So as of October 29th, 853,000 children had been reported as a COVID positive patient, and that represented about 11% of all cases in the United States, so including adults. So the rate is about 1,134 cases per 1,000 children. So within the past 2 weeks, they had an increase of 61,000 new pediatric cases. And in October alone, they gained nearly 200,000 COVID-19 cases for pediatrics or for children. And so this data was taken from 49 different states, New York City, DC, Puerto Rico, and Guam. So some of the limitations of this data that they had presented was that some of the, again, format and content and the metrics of the data were presented differently from state to state. Some states classified a child as anyone under the age of 17, 18, 19, or 20. So again, that variability also could affect the numbers as well. And we also don't know how many children have been infected, but maybe not tested and confirmed. Again, so asymptomatic versus symptomatic in the US, from the American Academy of Pediatrics, they had listed that at this time it was unknown the percentage of patients or pediatric patients that were asymptomatic versus symptomatic in the United States due to the variability in the data. But a MMWR that was released by the CDC pretty recently, it was October 2nd, showed that with the data collected from approximately 37 states between May 31st and September 13th, almost 277,000 children between the ages of 5 and 17 were a part of this study, that 5% of them reported no symptoms but tested positive for COVID. Approximately 58% reported at least one symptom, and 37% showed missing information. So again, a limitation was that this data might be an underestimate of the actual incidence in school-age children, because testing was frequently prioritized for people with symptoms. So kids that were asymptomatic may not have been tested. So this is just a picture of the chart that was listed in that article. So you can see here the total number of positive cases for children, as well as the symptom status. Did they have symptoms versus not? And then how many of those cases had missing data for symptoms. The reproduction number. So we had a couple of articles that had come out since I had written my paper. It looks like the Gunsler and Seagal article, the reproduction number was predicted at about 4.02, had declined to about 1.51 in the United States between March 17th and April 1st with all of the lockdowns. But they had noted that since then, it may have increased again because they were in the process of easing up some of those restrictions. And then the Al Rayi article that I had also looked at, it had taken data from a variety of countries, such as the United States, China, France, Russia, India, and a couple of others, and came up with a collective reproduction number for all of those countries, and it was anywhere between 1 and 2.8-ish, with a reproduction number for the US at about 1.6. So again, from this data, it can be concluded that people of all ages are susceptible to COVID, and again, that children are less likely than adults to contract it and to ultimately die from COVID. Children present with milder symptoms than adults and are less likely to require hospitalization, and that the reproduction number has decreased since the beginning of the pandemic, but is still above a 1, which means that it's still pretty contagious. So that's all I have for my presentation. Does anybody have any questions about independent studies, about my specific project, anything like that I can answer?
Hey, Jenny, it looks like JD has one, and he's asking about any data. Is there any data that's comparing numbers between public or private or homeschooled children?
So I haven't seen any. My guess would be that the American Academy of Pediatrics and the CDC would be the best sources of information. But in terms of comparing those numbers, I don't have that data, and I don't think they do either, because that was a limitation based off of, how the data was documented in the state by state variability and how they were doing that. That's a great question. I would love to see that though.
So with your great talk, by the way, that was really interesting. And it's still so relevant as we're I don't know about in your specific area, but where I am, public schools still have not gone back. They well, some of them have. They were targeting like November, but the district where the city where I live, they pushed it back to January. So, you know, everyone is still looking for the right answer on what to do when it comes to kids. So, with what you saw with the numbers, the total numbers of cases, the numbers of kids that are asymptomatic. I know I'm kind of putting you on the spot with this one, but what do you think is right? Like, should we be keeping schools closed? Should we be doing the hybrid? Should we be open and just be careful?
Yeah, I think that's a great question. And, you know, that was a question that I think a lot of schools across the country are still asking.
Yeah.
There really is no right or wrong answer. I feel like, you know, when asking around to some of my patients and asking what, you know, they're doing in terms of school, some schools are offering hybrid learning. Some of them are offering full-time online. Some of them are offering in person. And some of them aren't even giving choices. They're just telling parents and families, you know, hey, this is what we're doing. So I think it honestly just depends on the school itself, the amount of funding that they're able to get to implement some of the CDC measures, you know, and also community buy-in too. I think one of the biggest things that my mom's school district in particular, so she's a school counselor, and one of the biggest issues that they're dealing with right now is community buy-in. So they're implementing all these safety measures at school. They have a protocol for quarantining anybody that was in contact with someone that was COVID positive. But then you have, you know, parents and kids in the community that are out and hosting parties and watch parties for football games and all of these
Yes.
things. So I think it really just depends on the community, how much buy-in you have from them, you know, what the school is capable of providing in terms of safety for everyone, and you know, participation with everyone. It really is a team effort. And I think that, you know, unfortunately for some schools, that's, you know, getting the proper funding and being able to provide a safe space for some of those kids isn't really an option.
Very true. I have a friend who's a public school teacher, and she even has to buy her own cleaning supplies for right now. And I mean, it's heartbreaking.
Right. Especially when it's hard to come by still too, you know.
Yeah, very true. Does anybody, Dr. Langridge says, could you comment on your own clinical experience? For example, on your clinical experience about transmission within homes. Recent data suggests that the within home transmission is high, but not 100% of persons within the home.
Are you talking about like at the hospital, what I'm experiencing with parents and families?
Yeah, I guess I'm also asking about, yeah, your personal experience, what they're telling you, what you're observing, uh, and such.
Okay. Yeah. So right now, I think, you know, anybody that's coming in for an outpatient surgery, because that's my main clinical area, the pediatric patients are required to get COVID tested, but parents are not. So I think that's kind of a limitation as to what our testing is capable of doing and protecting healthcare workers and protecting other patients at our hospital too. We kind of just have to give parents the benefit of the doubt that they're not COVID positive, and that they're quarantining. So right now our quarantine period is, so from the time you get COVID tested to your actual surgery, it's about 5 days. So we're requiring families to quarantine for 5 days, which is a lot, especially if you have multiple children, if you are an essential worker, if you don't have anybody else to watch your children, you know, whatever the circumstance may be. That really adds like a huge challenge. And I've noticed a lot of outpatient areas that are requiring COVID testing for sedated procedures, surgeries, scans, things like that. We've seen a decrease in the amount of patients we're seeing right now. And my colleagues and I were actually just discussing this the other day. We're not sure if, because schools around here are going to be closing between Thanksgiving and Christmas to kind of allow, you know, college kids when they come home, for families to quarantine with all the holidays and things like that, to ensure that we have the least amount of spread or potential to spread once kids come back to school. So I'm thinking that a lot of families are waiting until then to start scheduling more of those elective surgeries and scans. So that's kind of affected our clinical practice as well and what we're seeing. Did that answer your question?
Yeah, it did some. 5 days from the time the child is tested
5
until
days.
they're,
Yeah. So it initially was 3, but because we outsource most of our testing to an outside vendor, the turnaround time of 3 days was a little variable. So we would have patients come in for their surgery and the test wouldn't be back yet. So having to swab a child a second time does not go over well with anybody. So to be on the safe side, we typically do it 5 days out now.
and do you get the results back within 3 then often?
Yeah,
Or is it,
oftentimes it's within 3 to 4. I
okay,
haven't seen any issues with the 5-day
uh-huh,
mark.
uh-huh. And so, but, how do these data from these studies compare to what's happening at Hershey? Do you know, in terms of the percent of cases that are within this under 17 age, or the percentage that have no symptoms? Do you
Yeah,
have any idea of?
I do
Um,
not. So I typically don't cover the inpatient world. I do know that so I worked this past weekend and we had a couple of pediatric patients in our care. But I don't know how many we've been averaging.
mhm.
So when we have the COVID-19 dashboard for Penn State Health, I believe it's public knowledge, so you can look it up and see how many patients are in our care that are COVID positive, but it does not give a breakdown of how many pediatric patients.
And then you don't see those data as a part of your own clinical practice.
No,
Okay.
no. So our department specifically, so any type of psychosocial services, if a pediatric patient is COVID positive or suspected COVID positive in the emergency department, we are not permitted to go in the room.
Hmm. So just about how many pediatric patients have been positive on your test that you've given?
The ones that I've been a part of.
Yeah.
So with where I'm at with COVID testing, it's for our outpatient surgeries and
Right.
procedures. So they're assumed negative unless they come back positive. And as far as I'm aware, none of my pediatric patients have come back positive, but it
Uh-huh.
could be that they just didn't notify me. It's a strong possibility.
Uh-huh. Hmm.
So
I just want to
go ahead.
check real quick. Heather, are you logged in? Okay, it didn't look like it.
Jen, if I could give a little update on what she had done, if you
Sure.
want, but I don't want to close out the discussion with Jennie.
Oh,
So does anybody have any other questions? You can either unmute yourself and speak, or you can just type it into the chat and I'll read it for you.
Well, Jennie, I would ask you also, not to hog the conversation, but did any of the data surprise you as you were doing this, or surprise other people that you were able to talk to?
I didn't surprise me. I think the American Academy of Pediatrics data that they just released, they keep updating it. And it's hovering around 11% still for the incidence rate, which is kind of what they've been hovering at. But the fact that we've had over 200,000, almost 200,000 pediatric cases just in the month of October alone makes me question, what it's going to look like after the holidays and after everyone's been around family and things like that, if they choose to do that.
Mm-hmm. Yeah, well, and you are seeing patients which are coming in for some sort of procedure, so that's not necessarily a random sample of the entire pediatric population.
Right. And unless they are unless it's like an emergency or a surgery that needs to be done immediately, if a patient comes back COVID positive, they're not going to do an elective procedure. They're going to cancel it and reschedule.
Mm-hmm.
Just because of the lack of resources and having to clean and things like that.
Hmm. So how many child life specialists share your responsibilities at Hershey?
So anywhere that a pediatric patient is at, for the most part, we are present. So I think we're hovering around 20 child life specialists now total, but amongst the whole team. So we have support staff and assistants and things like that that are a part of our team as well. We have a rec therapist who also does interventions with pediatric patients as well. But we're about 20, and I think that includes our 2 facility dogs as well.
Aw,
Yeah, they're awesome. So they actually just came back a couple of months ago. There wasn't a lot of data to support whether or not COVID-19 is easily transmittable on animal fur and things like that. And just with the level of precaution the hospital was taking, we just felt that it was best to not bring the dogs in for their safety and for our patient safety as well.
so Greg wants to know across the states, if there were any state or states that were had lower rates compared when any states that had lower rates compared to the other states.
I'm sure the American Academy of Pediatrics in their most recent update, they did break it down by state. I didn't look into it into much detail. I kind of just wanted to get the basic overview. You had some, I know I read that some states had as high an incidence rate of 15% or more, whereas others had lower incidence rates. So I think it kind of just depends on, where the states are at in terms of restrictions and things like that. So, let's take Pennsylvania, for example. We're still operating at a lower capacity in like restaurants, and we have all those precautions, whereas Alabama, for example, does not. So.
Yeah, I would expect schools are a big part of that transmission process
Yeah.
as well, preschools.
Yes, it's very hard to have a preschool age child to keep a mask on and then put things in their mouth. All developmentally appropriate things, but
Yeah, well, it's recommended for 2 and up, right?
yep.
Okay, does anybody else have any questions? It does not look like it, but if you come up with one while Dr. Lengrich is talking about Heather's work, just put it in the chat and I can still ask Jennie when he's done. So do you want to give a brief overview of Heather's work?
Yes, I can do that. This is Jean Lengrich. I had worked with Heather on her 596 project also during the summer. What she did was put together a curriculum for primarily for teachers and high school students of the, well, it's called the science of COVID-19. And here, if I can share my screen, Jennie, I'm going to stop yours from sharing. How's that? Can you see that, Jen?
Yep, I can see it.
Good. So Heather worked on a project which was to design curriculum for high school biology science teachers and their students, trying to capitalize on the idea of on COVID-19 coming about. So this was partially funded through some internal funds at Penn State. It involved 3 different groups here, and I can show you the modules. So there is a module on virology, a module on epidemiology, and then a third one on public health preparedness. And Heather authored the one on public health preparedness. But the idea of these 3 modules is to walk the student through what virology is. You act in that section. I'll just go to that and show you the contents here. I think we can get there. There we go. So it's actually quite quite extensive. I think this would be a challenge, would have been a challenge for me when I was in high school, I know that. But it talks about what is a virus, what's a new virus, what is a vaccine, how it's made, what kind of antibody response comes from, and gives you a summary as well as a quiz. But this is module 1. This was put together by folks from the virology department at Penn State. And then there was a second module, which was the epidemiology module. And this one walked through the modeling of infectious disease spread. So we heard Jennie talk about the R0 value. Well, that would be a very important piece in this training program here. So here's the SIR model, agent-based modeling. So you can see they went into a fair amount of depth on each of these in the module 2 epidemiology. And then the third one, which Heather authored, is on public health preparedness. So what we did, yeah, Jen?
I was going to say that we were a module behind you, but module 3 just popped up.
Okay, good. So what her module did was put together the explanation for what is public health, what are public health scientists. We gave them an introduction to who is responsible in public health preparedness. She talked about the whole idea of flattening the epi curve. And then we gave them some activities, which was to sort of go into a state site, and this in the development phase here is focused upon Pennsylvania. So they would go to estimating the healthcare capacity within the county in which they lived here in Pennsylvania. And then they would develop a prevalence curve from those data, and then also talk about what is the prevalence of vulnerable populations in their county. So the whole idea of this module 3 was to introduce them to what is public health preparedness, who does what they do, what are they trying to do, and how, and particularly paying attention to the vulnerable populations that may live in their particular county. So this gave the students an opportunity to really explore each of these groups. And then there were, of course, at the end, there was some summary and some quiz information too, I believe. Yeah, there's the quiz. She worked on putting this third part of the module together. What you're now looking at is the complete lesson in a development phase. And it actually looks quite good. It was put together from people at WPSU, our TV producing station here. Just click on what are public health scientists, see if we can get there and show you what that looks like. But they worked on making it appealing and engaging, gave it some nice pictures. So this is the development phase right now, and in probably another couple of weeks, the development part will come off of this project, and then the Center for Science in the Schools will test this in a much larger, well, test it in a sample of high school teachers throughout, I think they're going throughout Pennsylvania, and then they have ideas about trying to take it more nationally after that. So this was her project. So she developed a lot of the content and provided that to the Center for Science and Teaching in the Schools, who kind of put it all together, the 3 modules together, and then they sent it over to WPSU, which made it, and not only with that WPSU, but they had a instructional designer there as well. And so then they put this all together into this package now. And so hopefully it will get picked up and used by high school teachers and high school students and give them a good understanding of what COVID-19 is, what the virus is, what we expect from modeling and estimating numbers, as well as what public health preparedness people do. So that's an overview, Jen, and everybody else.
Thank you. That really looks great. So I know Heather's not here, but does anybody have any questions about her project that Dr. Langridge can answer?
I have a quick question about that project. What age group, so like what specific grade in high school is that going to be used in? And is that going to be in like general science, honors, AP level? Is the information going to change based on the level of student as well?
Yeah, well, that's a great question, Savannah, and I don't have a very specific answer for you because I don't really know. When Matthew started this project, he talked about it ranging from grade 6 up to grade 12. And I said, you know, that feels like a very broad range for me. The content will be extremely different. And my advice to Heather as she worked on this was to focus upon more of the upper age range at the junior and senior area. How it fits into a particular curriculum or an AP designation, I really don't have an answer for you, Savannah.
Okay, thank you so much.
So, you know, in my sense, it's you know, I'm not a teacher and I don't have children in school, so, but my sense is that teachers would welcome material that's online that they think they can use with their students. This is a very timely topic, but I do think the content is fairly high level. So maybe teachers could use it with a select group of students.
Yeah, that makes sense. Thank you.
Any other questions? Any other questions for Jennie?
No more questions for her, but thank you very much, Jennie. It was a fantastic presentation.
Yes, it was. I really appreciate you doing this.
Yeah, thank you so much for having me. Dr. Langridge, are you able to put that link to Heather's project in the chat box?
Yes, I think I can. I would